chat box then. Excellent. Adam's made a start, so add in your details in the chat box. We've got two main themes. One is around the issue of data and recording of homelessness and other inclusion and health statuses in NHS records. The other is around lobbying and to get some support from you and ideas about lobbying that you feel we can usefully do with other partners in the voluntary sector, and then we're going to go on and get an update from Alex. So I'll start by introducing Sam. Really, our thinking around this first session was we've been battling for a long time with the fact that the NHS is largely blind to the needs of people experiencing homelessness. They don't know that they're there. It's a big part of the problem with the NHS and other large bureaucracies is if it can't be counted, it doesn't count. And our patients are often invisible on a system. Over many years, we've tried to look for homeless patients in NHS systems through our faculty pathway needs assessments. We've looked for proxy markers like registration with a specialist GP or a hostel address or NFA on the records, and that worked reasonably well to start with. But over the last 10 years, we've noticed that the system, because it demands an address, often gets one. So our patients get less and less visible. And some of our more recent needs assessments, that process has shown up hardly any homeless patients. But then if you wander into the ED and say, how many of your frequent attenders or how many of the patients in here on a Saturday night have homelessness as part of a marker of complexity, or they'll say, oh, loads, a quarter, a third, a half. So our patients are there, but aren't seen. So that leads me into introducing Sam Dawley-Smith, who he's going to tell us a heroic tale of tenacity over 10 years of wrestling with NHS data challenges and some recent moderately encouraging signs that the system is starting to listen to us. So thank you very much, Sam. I'll hand over to you and get you to share your slides.
That's somewhat overstating it, but hey ho. Hello, everybody. For anybody who doesn't know me, I'm Sam Dawley-Smith and I'm the Nursing Fellow for the Pathway charity. And yeah, we're just going to do a quick canter through what we've done in terms of progressing things on recording housing status in health data sets. So I can't move this on. Yes, I can. So I'm sure many of you will know that the NICE guidance was published recently, and you can click through onto it if you would like to. But one of the things within the NICE guidance is that it says that people need to work with health and social care providers to improve recording of housing status. So that information can be used to meet people's needs and plan, audit and improve services. And we were somewhat delighted to see that, and it's quite early on in the planning and commissioning part. So, hopefully it will be taken notice of. And I suppose there's a question about, so why is it there? What's it referring to? Well, as Nigel has said, is that currently really the only way to identify people experiencing homelessness in data sets is to try doing a search on NFA. And we know that many more homeless people are hidden and that their homelessness is not immediately visible to healthcare practitioners themselves, and therefore also in the data. And we also know that actually some people are recorded as NFA who aren't, so people who are collapsed and stuff like that. So it's a really complicated picture in terms of understanding who's homeless and who's not in terms of the data. But overall, in terms of the research, we know that all forms of homelessness are bad for your health. And without being able to identify it, we're not going to be able to plan services and track outcomes locally. And as Nigel said, so I've been involved in many needs assessments along the way. And what we do when we do a needs assessment for a pathway team, as he said, we ask the business intelligence people to look at all forms of NFA in one hospital system. We actually found 31 different ways in which NFA had been put in the system. And we also give the hospitals a list of homeless hostel addresses, day centre addresses, the homeless GPs, and also the ZZ99 postcode. And what we know from that is that this method often doubles or trebles that original pickup on NFA, and can sometimes be more. And we also know from the pathway teams that that obviously when pathway teams start seeing people, then quite a lot of the people that they see have an address, they're sofa surfing, they're in temporary accommodation. So you've got another 20 or 30% of people on top of that. So good reasons for recording housing status, but in addition to planning locally for services to meet people's needs, we obviously need that housing status marker in health data sets to answer some of those big questions. So, for example, at the moment, it's really hard to kind of answer the question, does moving from NFA, from being a rough sleeper to moving into homeless hostels, does it improve your health or does it in fact worsen it? We don't know what the difference in health outcomes between people in local authority and private rented accommodation are. So attaching housing status to health would make a massive difference to what we know as a generality as to how housing relates to health. So you'd think that recording housing status in general was a no-brainer, but there is currently no recommended or tested way of recording housing status or indeed risk of homelessness in health data sets. And it's not true that I'm going to run you through the whole history of what we've done, because I think that would just take too long. But I think what we did think is when the Homelessness Reduction Act came along, we thought this was a massive opportunity in that, here was a statutory duty on health, on the acute, for them to identify people who are homeless or at risk of homelessness and refer them to the local authority. But you'd think, in order to identify them, they're going to need to be asking them some questions and then recording that. So it seemed like a real opportunity to kickstart the health service recording housing status, and indeed align it with other statutory areas like schools and prisons or whatever, where the Homelessness Reduction Act applied. So in the absence of an existing standard set of housing fields, we got together with a group of partners at that point to develop our own list of suggested housing fields. Ourselves a criteria of saying that we wanted a limited number of fields, something that was acceptable and understandable by patients. So, for example, sofa surfing might be something that professionals really identify with, but not necessarily something that patients want to identify themselves as opposed to maybe living temporarily with friends and family. Something that was understandable and easy to deliver by a receptionist and administrative staff, something where the terminology would be really easy to understand and obviously useful to clinicians in assessments, as well as being fit for purpose for research. And we also wanted to make this group of housing fields fit for the future. And we were mindful of the planned migration of all coding into SNOMED by 2020. And when we did this piece of work, which was quite extensive and took quite a lot of time, we did look into all of the really important coding sets, health and non-health, that included housing status recording. None of them were the same, including the NHS digital ones. So there were housing fields drop-downs within mental health community and emergency care, but they were all different. And we looked at the NDTMS, Fianza and HCLIC. I say all different in their extensiveness, in their terminology, all these kinds of things. And interestingly, at the same time, the Office for National Statistics did a piece of work trying to harmonise definitions of homelessness across the 4 countries, and after 18 months came to the conclusion that it wasn't possible to do, and really mirrored our experience of the terminology across these things not really matching up. So I noticed Jill's on the call. Lovely to see you, Jill. So at the end, there was a few of us from Pathway, Shelter, MHCLG, Crisis, Just Life and Find and Treat, that got together and argued out what we thought was the best set of housing fields, which had SNOMED codes associated with them, which were, we felt, as simple as possible and easy to understand, and divided into two categories of being stable housing or unstable housing. And they're up on the slide now, but anybody who wants them, we can send them to you. And we talked to experts by experience about this, because it was really important to involve them. We had 3 big focus groups. One had 22 people in it, and lasted 2 hours. So we did quite a lot of talking. And overall, service users really understood the potential benefits of asking about housing status and of recording it. So they were completely on board about why we would want to do that. However, they had some really valid points, which was they felt the rest of the general population might not understand this and would need, they'd need to be a public information campaign. They were worried that if someone was recorded as a rough sleeper, whether that rough sleeping would ever be taken off their record. And anybody who's had experience of trying to get their address changed on the hospital record will know it's really not that easy, and it's a legitimate concern. They were also very concerned, which I thought was, surprising and shows what people know, but they were worried about things like overseas officers, maybe looking at tags of rough sleeping and actively targeting those people. And I think that is a concern. They were also, clear that some people might feel sensitive about being asked about homelessness at reception desks. And obviously that's really important. And they said that homelessness is complicated, and even something as simple like living in hostel can mean a lot of different things to a lot of different people. And finally, they raised the potential issue that, perhaps knowing someone was going to be asked about their homelessness might put people off accessing services. So all of this was really, really important. But overall, they were really on board and they really understood why you'd want to do it. So we really wanted to take this work forward and pilot it, in a number of different settings with a number of different people so that we could develop this further. And at the time, we wrote to Jeremy Hunt, and explained what we'd done, that the homelessness was there, that this was a really key opportunity, that we've got work that we wanted to take forward.
I'm trying to pack something in my basket. I don't even know my basket.
There's somebody who probably needs to turn themselves onto mute. Thank you very much. We've all done it. So we wrote to Jeremy Hunt, and essentially we got a letter back saying, oh yes, great work. We know you've been doing that. There's no money, carry on. And that was the end of that. And believe me, in the interim 4 years, I've had conversations with so many people. And it hasn't really gone very far. To be fair, we've had COVID, there's been a lot going on. But there has been essentially a gap of 4 years where I've been sitting on that egg. But now, 2022, we've got a little bit of progress at last, which is really, really good. I always said it was my retirement goal. So, at this rate, it is going to be when I retire, but hey ho, some progress. Really great progress in that when we looked at all those data sets originally, one of the data sets, as I said, we looked at was the NHS digital emergency care data set. The housing fields drop down on the emergency care data set is mandatory, great, but it's actually woeful. And as you can see from this list, I don't know whether everybody can read it, this is the set of housing fields that are on there. And I can tell you that, because all of the obvious ones aren't on there, that it's not being used properly and people are just defaulting to not known, because I've been around to a few receptions and asked this question. But they have agreed not to go with our standard list, but to add in rough sleeping, sofa surfing, homeless hostel, and temporary and unstable accommodation. And that has been agreed to be added from October. This is a real potential game changer because it is a mandatory data set. So if we get, A&Es across the country actually recording housing status, then these people will be visible in all, in a wide variety of data sets across the country. The fact that it will be on the mandatory drop down, obviously, though, doesn't mean that the receptionist will necessarily use it. And obviously what we're going to need, so anywhere where the pathway teams are, we will be actively engaging with the A&Es and the A&E receptionists and whatever to help them kind of see that they've now got a sensible list of drop downs, and try and explain why it's important and how that can be linked to the pathway team services and all of that. But anybody who works in a hospital where they've got links with an A&E who is willing to work with us on this, or happy to work on your own on this, then please do get in contact. And then also, I'm really sorry, this is really small, I couldn't get a good picture of it, but Sophie Kerner, who couldn't be here today, worked on the review for the mental health services dataset, and the mental health services dataset have essentially taken our guidance. So they've completely changed their what was 34 housing fields, and all of their housing fields were all very mental health related, but they've essentially taken our guidance and the SNOMED codes, and they've put them into the new data set. You can access that online and have a look at that. So that is also really, really excellent news. So if we've got both the mental health data set and the A&E data set, recording some useful information, we may be in a very different place in a year's time. So, this is the faculty meetings are supposed to be about finding out your thoughts and your feelings and stuff like that and whatever. So we've got, I think, 10 or 15 minutes now just to get you to contribute. I mean, we'd like to hear from people what your challenges and successes have been locally at recording housing status or making changes around that. We'd like to hear from anybody who wants to join a reference group for overseeing on commenting on the work as it progresses. So this might be a time to review the housing fields set, but any time we're engaging, for example, with the reference groups, with mental health, with emergency care data sets, it's really useful to have senior people behind us saying, yes, this is the right thing to do. And also, if anybody, say, is working in hospitals where they've got A&E contacts who would like to be part of a campaign when this emergency care data set changes in October, we'd obviously like to hear from you. So open up the field to anybody who would like to be part of the discussion, I guess.
Smashing. Thank you, Sam. If you maybe, yeah, you've done it, stop the screen sharing. So if I could encourage anybody that wants to make a comment, don't worry by making a comment. You're not automatically adding yourself to this reference group. You're not obliged to do any actual work. There was a question in the chat from Colette about whether somebody sleeping in a tent is mentioned in the rough sleeping category, that particularly relevance to rural areas. What do you think about that?
So yeah, so Jill's here as well. I mean, it's really, really difficult, isn't it? Because for example, sleeping in container is a very common thing now, and I mean, you can go on and on. And when we started, I think we had about 35 different fields and felt that really we needed to aim for 20. It's not on there now, but there could be some really good reasons for adding it. I think what we tried to do was, and I can bring the fields back up, is just to go for what we felt were the most common ones. But this is why we want people to be part of a reference group. We want people to volunteer to be part of a reference group, because yes, you're right, we're London centric here, and actually, if that is a much more significant issue in rural areas, and this is a national data set, then it really is important, much more important to add it than I'm thinking. So no, it's not on there, but
I guess that could be a sort of category under rough sleeping. So to make just more in the guidance notes to make sure that when you say rough sleeping, that would include somebody in a tent or other odd place to sleep. Just thinking back to the discussions that we had with the emergency department people, am I right in remembering that they're also taking out the not applicable or not known option? So they're going to try and force the receptionists to pick a category?
Yeah, so they are going to try and do that. So they are going to take out the not known. I don't know what I feel about that. I'd be interested to hear what Shona thinks about that, actually. I mean, if you take out not known and people don't know, then they are effectively lying, aren't they?
Yeah.
So it's a really tricky one. However, I do understand in a mandatory data set, if you've got not known and people feel, you know, under pressure or whatever, it is a natural default. I mean, if anybody's got any other suggestions on that. I mean, I will say, I think this is going to be it's still going to be a slow burn. We've been talking to A&E receptionists about it. And for example, in A&E receptions, there's a lot of glass now. I mean, sometimes there was before, but people have got to speak through glass. Getting a conversation going is quite difficult. Even passing pieces of paper backwards and forwards is quite difficult. So it's probably not going to be easy for them. We want to do as much as we can.
Feel as though we've got you on your on like in the mastermind chair here at the moment. This is your special subject, and you've been given a bit of a feed here from Janine about GPs collecting the data, and so what's the current status and opportunities within the GP database, and is there any read across from primary care records to secondary care?
So obviously in primary care, you can code your own records. All of the housing status fields that I've talked about have, because they are so we did that deliberately, they have equivalents in EMIS, in System 1, in Vision, and you know, anybody who's interested can get in contact and I can tell you what they are. I can also tell you, if you're on EMIS or System 1, that you can access a template that was created at the same time as doing this piecework. So there is a homeless template. If you just type in homeless into templates on EMIS, you'll get it, and it's got the housing fields drop down in it. And similarly, you can get it from System 1. Just like anywhere else, there is no mandate for GP practice to record housing status. I don't know whether Armina's on the call, but one of our Pathway Fellows, this is a slight segue, but I think it's relevant, and has been looking really at screening for health inequality on the practice population, and she's developed a screening tool which looks at a wide variety of markers actually picked up from the homeless template to screen people to see who's at risk of health inequalities on the practice population, and her screening tool comes up with about 8% of the population. But one of the key things it is looking for is housing status, amongst other things. So I would definitely recommend that GPs start to record housing status, but there is no mandate for it. But anybody who's interested in doing it, so we can give you the tools to help you to make it a lot easier, if you see what I mean. Is that helpful?
Yeah, thank you. And so I think it's true to say that when the NHS is still plagued by different and computer systems which don't speak to each other. So the fact that somebody's tagged as rough sleeping on their GP records won't necessarily read across to the ED records, or the sometimes separate inpatient computer records, or the sometimes equally separate inpatient mental health record.
No, however, no, it won't. But so, for example, in hospital episode statistics, if you've got the marker in A&E, it will read across wherever you access the system within hospital episodes. So getting it on there, and similarly for the, I've forgotten what the primary care data is, you know, just so long as you've got it in somewhere in primary care, it will get picked up. So it is making a massive difference if you put it in once, you know, in your data set, in your GP practice. And Diana said, our definitions are provided. Yes, so what I actually had up on that slide was the advice provided to A&E receptionists for the original emergency care data set of drop downs, which was amusing to say the least. I don't know where they got their set of definitions and their advice from, but yes, they are very happy for us to be involved in rewriting the guidance. So there will be, and indeed I have done that already effectively. It's just waiting to be put into a document. I still think there's going to be probably need to be quite a lot of personal engagement on that. Lucy Holmes. I'm
Yeah,
interested.
so just while you're reading Lucy's questions, we've been kind of thinking through, we really need to perhaps offer some sort of training for ED receptionists so that they can be encouraged to find sensitive ways of answering these questions, and also perhaps helping them to understand why it's a mandatory data set and why it may be of benefit for the system, but more specifically for the patient. So helping them to understand why it may help us to help a patient have a better discharge planning and better healthcare by identifying those particular vulnerabilities. So yeah, Lucy's asking a question about mapping onto ONS and boats and boaters.
So Lucy, the mental health data set have done it exactly as we had intended, which is amazing. So they've effectively done a dual thing, which is they're recording stable and unstable accommodation, and then the housing status field. So for example, you could be a boater but stable, but a boater but unstable. And similarly, you could be in a mobile home, stable or unstable. I mean, it's a nuance, but it is a really important nuance, because you're right, we've got people living on the Thames in houseboats that are worth several million. I suspect they're not frequent attenders in A&E, so the extent to which they skew the data set is probably pretty small. They've probably all got private healthcare, but nevertheless, it is important, and it's really good to see that the mental health data set have really taken that on board and are really, really trying to nail that properly. But at the moment in SNOMED, there is only lives in boat. So you can only do it by doing an additional code. There isn't in SNOMED at the moment lives in boat stable, lives in boat unstable. With regard to SNOMED, getting changes in SNOMED is quite difficult, not impossible, but difficult. They like to see, and that's why getting people involved in reference groups is really important. They don't, if it's just me going along to them saying, please, can you add lives in container? They'll probably say, well, what evidence have you got that this is really important? Whereas if it's, you've got 15 people behind you who are obviously all very senior from different areas saying this is why it's important, you're much more likely to get it through. I have got things through SNOMED. So this is the kind of thing that would be really good to discuss further.
So there was a question from Diana Rosenthal about pediatricians, and obviously we know from other presentations that we've heard that half of the people in England and Wales in temporary accommodation are children. So it's a big issue, which again we're often blind to. Would you need to do anything different, or would these data sets identify somebody in B&B?
Sorry, I was just can you repeat that? Sorry.
So thinking about from the perspective of paediatricians and the housing status that they should record, half of the homeless people in England and Wales are going to be children, and they're likely to be in B&Bs and other forms of temporary accommodation. Would these data sets identify people in those situations?
Not sure I fully understand the question. I mean, you can record housing status against children in the same way as you can record housing status against adults. Are they currently I mean, no, homeless families are currently completely invisible in health data sets as opposed to other families for this very reason, because nobody's recording housing status against them. And it's really important.
But the same categories should work for a homeless child.
Sorry, I'm being really thick. Yes. Yes, the same categories should work.
Thank you. I mean, that's what I was asking, but I was also asking that when families go to see pediatricians, is there any other information do you think that they should be collecting, such as what is their housing situation like? What is the condition? Because what we are often seeing, I'm working with families in temporary accommodation, is that the conditions are really unsuitable and not fit for purpose. And I think pediatricians can play a much greater role if they write letters to housing saying this is actually hazardous for their child's health in terms of their development.
Absolutely. Are you in contact with Monica? I'm sure you are.
Yes, actually, I created the project Monica is leading.
Okay. Right. So Pathway, we are totally on board with that. I mean, I will say, I mean, sort of routine coding of the conditions of housing is majorly aspirational. I mean, just getting people to record housing status is probably the first step. Then, of course, whether housing is suitable or unsuitable would definitely be where we'd want to go with it, but hasn't been within our current thinking, not because we don't think it's important, but just because we think just getting this through is going to be.
I guess also the stages to this. So the
Yeah.
recording the housing status is an admin function from reception. If a clinician is then in front of the patient, and particularly if they see a flag of unstable housing or B&B, they should certainly be encouraged to go on to ask about whether the house is warm enough, whether it's damp, whether there's mold on the walls, what's the air quality, is there noise, how do they get on with the neighbours? All those kinds of things can be really helpful. And as Diana was saying, letters from doctors still do have some influence and can be helpful, particularly if they're couched in the right way.
Can I just answer Natasha? So with regard to where it's free texted in notes, I mean, it's always a great sadness to me that clinicians in hospitals don't seem to be able to code. Actually, James Norman in UCLH is being able to do that, but in general they can't. If it's not, and obviously there's big coding teams, and the coding teams look at the records, but if the coding teams aren't thinking about, you know, coding for homelessness, they won't do it. I mean, most of the hospitals that I've ever worked in, not all, so SLAM, for example, can do free text searches, aren't able to free text search for homelessness. So they are able to come up with a cohort of people based on searching free text on the records. Natasha, I don't know where you are. If you are able to do that, and you think that people should be able to do that routinely across all sites, it'd be really interesting to hear about that. Jill, I wonder whether you wanted to come in with your comments, because it would be lovely to hear from you. And Alex, I can see you've got your hand up.
Alex speak first. He had his hand up.
So Sam, I mean, I think it's just it's so important, this work, and potentially so powerful. But I was just thinking back to the EBEs and this question of these markers, particularly, for example, rough sleeping. Will it, and I should know this, but if I'm flagged as rough sleeping this week, and then I'm in accommodation, will we get a history record of my housing status on the record? Or will it just always be if it's changed, then I become a housed person, and the history of rough sleeping I may find elsewhere in the record, but it disappears. Do we know this?
It really, really depends on where it's written in the record and how the record is constructed. And at different sites, that would appear to be different. So in some cases, yeah, it could stay on the record forever. Unless somebody manually overrides it. In some other cases, it might automatically disappear and you won't be able to ever know that it was there in the first place. And
that was something the EBEs talked about quite a bit, didn't they? Kind of, and they could see the benefit, particularly the research and other benefit about that history of someone's housing, but also that marker being stuck on me forever, that once rough slept. And that's tricky, isn't it? It's complicated.
Yeah. No, I mean, that's all. These are all big problems with it, but it's all baby steps. Jill, go on.
I don't know what you wanted me to say. I was just adding in some thoughts in the chat, really, about where we can go.
What your thoughts are
next. Well, no, it's just that there's still kind of opportunities to do stuff. I mean, yeah, I'm in the organisation in NHS England, and I still have the same context that I had when we updated the mental health service data set. So I guess it's just a case of being clear about what we need to do next. So all of the, I mean, you know, Sam, but all of the health service data sets get routinely reviewed and updated on a 3 and 1 year cycle. 3-year big review, 1-year little review. And then the thing that sits underneath all of it is the NHS data dictionary, which I did have a promise from those who I helped with on the mental health service data set that we would revisit. I just need to hack back into my old email address and find out who it was that said that we could revisit it. Otherwise, there's also a very useful person to know, but Emmett Roberts' dad is in fact someone of quite significance in NHS Digital who is very helpful. So we could just talk to Dave and ask him for his view as to what we do next. But yeah, DH and NHSX published the data strategy yesterday, which has been out for consultation for over a year now. And when I was in OHID, we were really trying to get colleagues to realise that what they're proposing for inequalities is very focused on ethnic minorities as opposed to broader or health inclusion, in fact. And having had a quick look at the strategy, I don't see anything specific that they've recognised in what we've said to them. But there is something about, well, great, you've published this strategy about data and you talk about health inequalities, but in practice, so what? So I do wonder whether there's a bit of a follow-up there. I don't know, like I worked with UK HSA on the Primus service back last year, which includes 7 codes, which again I will need to dig up, but they are taken from the mental health service data set. So every GP service provider has those 7 codes, and every GP was required to have them put in there because they were the flag for whether or not someone was JCVI priority for vaccination. But I just don't know the extent to which they've been used. And I did ask the question of UK HSA, I've just never had the answer. So we just need to go back and see what analysis is possible.
Thank you. That's really helpful. I love that. Data saves lives, and that's I've saved the link and share that out with the faculty. So I'm mindful of the time. Shona, maybe a last comment from Shona, and then we'll move on to the next topic.
Hey everyone, just to say, Sam, this is amazing work. I have a sneaking suspicion we're going to see homelessness rise though come the October when we're actually accurately tracking it. Yeah. More in response to Alex, so it's going to change from trust to trust, but locally if somebody is coded as homeless, as soon as an address goes on the system they actually come off, so it won't be a long-term alert on the system. And I know this from focus groups that I did when I first started in Post a couple of years ago. I had this bright idea about homeless alerts and how we needed to make people visible, but actually people felt really victimized by that. And there was 2 stories of people that, because I'd added an alert so they were visible, very well intentioned, but they felt that they were treated as homeless people when they next came to the trust. So if it's just coding, so they'll go down on that one attendance as a rough sleeper, but as soon as an address goes on the system, it comes off. So I get a no fixed abode report created by our business intelligence team. But as soon as an address goes onto that, the person comes off. So it shouldn't be a long-term marker on their record.
Which is positive and negative, isn't it? Because it's people who have experienced rough sleeping probably are a really useful subset of the population to find out more stuff about. So a number of people have been foolish enough to volunteer to get involved in a reference group in the chat there. So we'll scroll back through those and rope you in. And so thank you very much for that discussion. Thanks, Sam. That was absolutely fascinating. So I'm now going to pass on to Dee O'Connell, who is relatively new, not entirely new, been around for a little while now, head of policy and programs at Pathway. And Dee can introduce herself and this next topic.
Hi, thank you so much, Nigel. As Nigel was just saying, I am the new-ish head of policy and programs at Pathway. I joined in January and had previously been a civil servant and had been at what is now DLUC for a long time. I am going to take you through a short presentation today that's going to talk a bit about the Pathway policy function and how we're shaping that now that we're growing a little bit as an organisation. Excuse me. Then I'm going to take you through the huge avalanche of policy documents and changes coming out of government at the moment. I'll give you a flavour of those. Then I'll set out what we at Pathway think of as our policy and influencing priorities. And I'm going to end by asking you your opinions. So I hope we can keep most time for the discussion at the end. So to begin with, we are very fortunate in Pathway to be able to bring together lots of different people with different perspectives on health and on inclusion health. And I firmly believe that we are stronger together and can have more influence if we draw on all of these voices. This is not a new thing that Pathway does. We have always had influence in policy and in practice. What has changed is that we're just putting more time and energy into that function, which we are able to do because of our partnership with Crisis and the extra resource that that brings. So here's what we draw on to do our policy work. So I think the richness of experience that informs our policy work comes from our experts by experience, our hospital partnership teams, our fellows, and you in the faculty. And what that really turns into is lived experience, frontline experience, and new research and evidence. And the way we want the policy function of Pathway to work is to bring all of those things together to change policy and to influence practice. And we're helped in that, again, by the partnership with Crisis, who have a very big policy reach. Here are some of the assumptions that we're making about the Pathway policy function that I thought I would share. So our thinking is that we think there's actually pretty limited scope to influence any of the fundamentals of policy at national level over the next 2 years. This government is not in a position to, nor is it going to want to do anything big, expensive, and difficult while it just doesn't have very much gas in the tank. So the opportunities for the next 2 years are really around influencing service provision and commissioning, improvements to existing policy, and influencing parliamentarians and decision makers, like through the all-party parliamentary group on homelessness. So that's our focus for now, for the next couple of years. At the same time, though, we need to be thinking ahead to longer term ambitions for more radical policy change, looking ahead to the next general election and the development of manifesto commitments. I think the key, moving on to current policy coming out of government, I think the key thing to say is that there's a lot of it. It feels like there is an avalanche at the moment of consultations, bits of guidance, new legislation, and so on, which is inundating the landscape. And it's actually quite difficult to pin down what's going on. And you really feel the lack of a Jill Lang in central government telling you what's going on. It's become much harder to pin this down since she left. So there is an awful lot going on. And what I'm going to do now is just really canter through the big things. I'll send these slides around, so feel free to digest them at your leisure, because there is a lot here. I suppose the big thing that we've been quite focused on is the health disparities white paper. So this comes out of the government's levelling up agenda, which you'll be familiar with, and it's a really specific piece of work to focus on health inequalities and disparities. Its big focuses are going to be on geographical inequalities and health inequalities that arise from people's ethnicity. So I think it's important to be realistic that that's where the big changes are going to be. But we are in discussions with OHID about what are the sorts of things that we would like to see on inclusion health. And the sorts of things that they are thinking about are to do with overcoming barriers to primary care for inclusion health groups, discharge to the street, and joining up the kind of very limited data that exists on people experiencing homelessness. Then you can see right across the rest of the slide the other kind of bits of new policy and development at the moment. So the NHS long-term plan is a big one. The last one referenced pathway teams. The refresh will hopefully include some metrics that the government can use with NHSEI to track progress on health disparities. And of course, there is a new rough sleeping strategy coming out where I'm told the big area of joint interest between DLUC and OHID is on greater progress on social care. I'll say a bit more about social care on the next slide. If you're at our mental health faculty meeting last week, you'll have heard a lot from Sophie Kerner about the mental health 10-year plan. That consultation is live at the moment. We can send around the link to anybody who's interested in responding to that. But there is also reform going on of the Mental Health Act with that very grand ambition as described there. And obviously we all care very deeply about how mental health services are delivering for the people we care about. So that was all the new policy. This is all of the guidance, documentation, and so on that's coming out of government now that flows from what was last year's new policy. So you'll all be aware of the Health and Social Care Act. There is a lot going on to implement that successfully, focusing particularly on giving guidance to ICSs around producing their local strategies and on the duty to cooperate. We at Pathway think that this is where most of the progress over the next couple of years can be made, and we are working with the King's Fund to support ICSs to deliver on inclusion health, and Alex and I can say a little bit about that later. Something I think is quite exciting is that OHID are doing some work on social care, which has been a bit kind of low level and in the background, but shows really that they have clocked the sorts of things that Sam and others have been talking about for a long time to do with self-neglect and safeguarding. And they are working with the chief social worker and the chief public health nurse, as well as ADAS on best practice, which is very welcome. Then the last thing I just want to touch on is the new NICE guideline on working with people experiencing homelessness. That was a huge win. And what we will really want to see government do is support the implementation of that successfully. So that is a very quick canter through all of this blizzard of documents and new policies that are coming out of government at the moment. What I want to move on to now is an overview of the reform asks that we in Pathway have developed, and we're really grateful to have worked with partners in Groundswell, Mungo's, Crisis, and other charities in developing these. And with those organisations, we're working to see how we can really deepen and broaden that coalition so that we're all speaking to government with one joined up voice. So right across all of the policy opportunities that are going on at the moment, here is what we are looking for. Some of them we think are reasonably easy and straightforward asks. Others, however, are really quite ambitious, and we are realistic that they could take a number of years to achieve. So down the left-hand side there, you can see what we might call kind of system enablers, the sorts of things that we think are necessary to make the system work better for people experiencing homelessness and other inclusion health needs. We think that's around greater visibility of inclusion health groups, and that's exactly what Sam is having such success with at the moment. An ambitious target to focus efforts and concentrate minds. And we also think that the funding formula currently is not flexible enough to allow local areas to meet the needs of inclusion health groups. And we think that needs to change, which is happening successfully in pockets of areas around the country at the moment. We think other new policies that need to come into being are a duty to collaborate between health, housing, social care and criminal justice agencies, building on the duty to cooperate and the duty to refer, but going further and deeper. A clear accountability mechanism for when things go wrong. So we know that GP surgeries and CCGs and so on can do perfectly well and be judged to be doing well, but cannot be meeting the needs of inclusion health groups. And we think there needs to be greater assurance, greater accountability to hold people to account when that happens. We think that in all of the workforce reform happening across NHS at the moment, there needs to be a specific focus on inclusion health workforce, recognising the vicarious trauma and additional stress that people working in this area suffer from, but also raising the profile and awareness of inclusion health among what you might call the mainstream NHS workforce. And then finally, our last set of ideas is really around ICSs and making those work and making the delivery of the NHS, the NICE guideline a reality. So we'd like to establish a number of trailblazer areas to go further and faster on inclusion health. We'd like to see a lead responsible person for inclusion health in each ICS area. And of course, we would want to make sure that there is user voice at the centre of commissioning and planning in ICSs. So we have a long paper that sits behind this, which we're really happy to share with anybody who would like to see it. But those are the headline policy asks that Pathway is thinking of at the moment. We are very keen, however, to find out what you think. This is just the beginning of our thinking. As I was saying earlier on, it's vital that we hear from you because it is the faculty's experience of working in this space and experiencing these day-to-day challenges and issues that will really bring the richness of information to our influencing efforts. So we are really interested to know, who do you think we should focus our influencing efforts on? Is it national government, ICS level, PCNs, or somebody else? What are the biggest changes you would like to see happen? And finally, how do the barriers you face in your day-to-day work get in the way of your work for inclusion health groups? Because we're really keen to understand more about the problems you face and where we think we should be trying to do some problem solving. So I hope we can spend some time talking about this now. I'll put the questions in the chat as well. And my details are at the end of that slide. Thank you.
Smashing. Thanks very much, Dee. I think the best way of managing this, if we can, would be to get people to virtually put your hands up with the little reactions button, and then we can draw people into the conversation. And while people are thinking about that, I'm just thinking back to a meeting I had last week about the duty to collaborate from a public health doctor at OHID, and there was quite a lot of or was it the meeting with Amina about her secret shopper research? Possibly it was that meeting. Lots of meetings. But the pushback was, how do we frame these recommendations and these sort of pushes to the system in the context of most of the system being on its knees, and particularly general practice, but equally emergency departments, yet another set of things that you've got to do with no more time and resource. Do we have any thoughts about that yet? Shona has that. Shona is the perfect person to discuss this because she was both on the NICE guidance committee and is head of safeguarding in Gloucester. So she is the embodiment of the intersection of all of these areas of interest. So go for it, Shona.
Absolutely. I think you've just hit the nail on the head there. The system is on its knees. We are maxed out from a hospital point of view. Our primary care colleagues are also really struggling. I'd love to see more of a focus on the ICS. I think at the moment, my feedback so far is that actually there isn't much buying from an ICS point of view, because they go, well, we've got the services, you're doing a grand job, Shona, crack on. And I'm going, well, actually, no, I could do with some more resources. We need to expand. If we want a truly integrated approach, it takes resources. So that's my challenge at the moment, is trying to expand on what we've done. But it seems to be the same, that it's different ICSs are doing different things. So I'd love to see more support. The research is there now, the guidance is there. It needs to be implemented. We can't go straight to the front line. Like you say, we can't add in workload. So it has to be really well thought out. And I think that comes with resources and support from the ICSs.
Yes, thank you. The way the discussion went in the meeting was exactly that. And also thinking about anything that we do offer can perhaps be framed in terms of, here is a way in which we can make it easier for you to tackle some of the difficult situations that you're presented with, perhaps knowing that you're working with somebody who's experienced homelessness or has a history of rough sleeping may be of help in reducing the frequency of their attendances in the emergency department. That kind of framing might possibly be of benefit. Dee, the ICS work, could you outline the thinking of where we're going with the King's Fund and what we're going to do there?
Yeah, for sure. And Alex can jump in as well if he would like to. So really, this is approaching it from exactly the same place as Shona, which is to say that getting the ICSs on board with this agenda is just one of the most important things we think needs to happen. And the partnership with the King's Fund will invite ICSs to take part in what you could call, we need to come up with a better way of describing this, either a learning journey or an action learning set, which will take them on a learning journey that to understand better how they can commission and provide services for people with inclusion health needs. Jill is actually working on it for us, and she's come up with 5 themed sessions that we want them to take part in. And it will be a combination of them talking about their own problems, people who are doing well in those issues coming in and offering some advice, and then other people with kind of advice and good practice and evidence to contribute as well. We would like from that group to create a sort of an alumni group of ICSs who are interested in this work, and we'd like them to act as ambassadors to other ICSs to persuade, influence, cajole, tell them it's not that difficult around the area of inclusion and health. We'll also have spin-off products and reports from it as well. So advice and guidance that we can produce that other people can refer to. So letters are going out this week. So those of you who are working in a healthcare or ICS context, if you could watch out for those and in some way nudge chief executives or senior people locally to watch out and respond favorably, that would be really, really helpful. We can send you a copy of the letter as well so that you can see what it says and you know what it's all about. I don't know if Jill or Alex want to come in with anything else on that project.
I think you've covered it really well, Dee, but I think what's so interesting, the conversation with the King's Fund is about what one of their interests is, can we get this to become something that the chief exec, the board, the finance director, so that it's not seen and immediately delegated down 4 layers to be some marginal thing, as you said, Shona, but to stay, actually, this is the level of health need is very significant. And also in a way, as you said, Shona, there's now some pretty good evidence as to what to do, which is going to make a real difference. Yeah. And therefore, perhaps, and the initial roundtable we had, perhaps in this wider sea of real challenge in terms of being on our knees, money, overwhelmed, here is perhaps a place of the world where some good could still happen, which would make some real significant gains for some of the most excluded. So there's a piece in the thinking about how do we can we do something which does get ICSs at that senior level to give a damn and to be engaged and to keep them on it. So that's part of the trick. And my hope is that the kind of King's Fund's cachet, if you like, or whatever, is the kind of organization where they try and get senior people engaged. So that's the intent. But we shall see. We kind of how does it play out? Can we sustain that? Because the temptation, I'm going to the NHS Confed thing tomorrow in Liverpool, but one has the experience often as soon as you're the charity sector, the third sector, and the kind of lobby groups, senior FDs kind of say, oh yeah, look, we've got somebody who deals with that, go over there. It's very easy for you to be pushed aside. Jill, do you want to come in? I see your hands up.
Yeah, it was just, I don't know what people think, and it's just a reflection from my current role in NHS England is that I think we perhaps don't understand yet, or it's all immovable fees, but the regions and the regional role is actually much stronger, or is increasingly going to be a role that will have more importance, and particularly around inclusion and inequalities. And I mean, I work with all 7 regions on vaccine inequalities, and what's really been interesting is the role of the regional finance director. And I suppose it's that handoff between NHS England saying, well, we're not going to tell you exactly what to spend the money on because you're best placed to understand your communities and you have operational flexibility. But then there's this bizarre thing where that floats down to a regional allocation, down to ICS, down to local level. And there's no clear direction. There's no consensus as to what do we mean by action on inequalities or indeed inclusion health. And yeah, there's just a real lack of shared understanding throughout that kind of whole chain of geographies as to what do we mean when we talk about things, and then who has what role. But yeah, at a regional level, the region equalities leads, inequalities leads, of which there are several depending on which bit of the programme you're involved in, but there's not even consensus between them at a regional level as to what they mean and what they think ICS should be doing. So I don't know, it's just something that I think we'll have to reflect on within the King's Fund work, is how do we take the regions with us? Because actually they are the ones that will remain in perpetuity, providing a level of assurance. But what are they assuring against right now? Which, to be honest, it's impossible to see. Yeah, so I think we can, but I don't know how others at a more local and operational level ever even come into contact with the regions. It'd be quite interesting to know if anyone's got any experience or thoughts.
Interesting to bring Sarah Stiles from Leicester in here. She's made a comment in the chat about primary care networks and CCGs, which are then kind of the next layers down. Sarah, what's your experience of trying to get heard?
Yeah, I think actually I'd say the main thing is I'm struggling to understand what the systems are like at an ICB and ICS level, to know where the best place for our voice to be is. And I'm not sure whether that's partly because of where we are in Leicester at the moment. And some of what I've understood is that I'm not sure that everyone else fully understands what it's going to look like. But it's been, yeah, we've got some contacts within the CCG that we're trying to keep close and make sure that we still have those contacts, but it's quite hard to see where our voice fits into the ICB and ICS at the moment, I would say.
Thank you. And you also make a point about the flexibility. I mean, there's the additional roles reimbursement scheme, which comes through the PCNs, which provides a wide range of potential roles to support primary care. But I put a request out to the faculty last week asking for any examples of where the system has been bent a little to make that applicable to inclusion health populations. And I had one example come back from Exeter, and it seems, you say, that kind of rigidity of thinking is making it hard to get funding flexibly applied to imaginative ways of tackling the needs of people with complex needs.
Yeah, I think with the additional roles, it probably comes down to the individual PCNs and the ways of working, because if individual PCNs are prepared to be flexible and, for example, say, we understand that your patient group are not going to use this role so much, but actually let's say that we employ, I don't know, for example, a care coordinator just for your patients, and they can really get to know your patients and your team and then work well. I think that can work really well. So I'd say that in some ways that individual practices probably can influence that part of it. But we've found that other kind of policies or things that NHS England say that PCNs need to sign up to in order to get funding. An example would be the CPCS pharmacy scheme. It comes down to say that everyone within the PCN needs to sign up for that. But actually for our patient group, we felt it was unsafe what we were being asked to do. So we declined to sign up for it, which then has an impact for the whole PCN in terms of funding. And I just worry that the voice is going to be lost of our patient groups unless we each time have a bit of a fight about the areas that we feel don't fit for our patient groups. But my experience of that is that you need to go to NHS England. The way we got that sorted out was through contacts at NHS England rather than locally. But I just feel that our groups need to be represented when different policies are coming out through NHS England for PCNs to follow.
Right, so you actually went nationally to try and sort that out rather than, I suppose, the regional structures are all relatively new, aren't they? Then?
I think it's because the CCGs are, my understanding is that they're doing what NHS England are telling them to do for quite a lot of the funding that's coming through PCNs. So their response was that they've been told by NHS England that needs to happen. So it had to go back to NHS England to get approved. It did get approved, which is really encouraging, and we've not needed to sign up for that bit, and our PCN have still got the funding. But it's just, we just need to keep going with those bits, and it would be nice if our group of patients were kind of considered before it came down to that point.
And that's a really interesting example, Sarah, because that's the sort of thing that it just wouldn't have crossed our radar, and certainly nobody in OHID kind of thought about it clearly at a national level. So it did just come out centrally from NHS England, and as you say, nobody thought about our group. So it would actually be really helpful to kind of gather more of those sorts of examples so that we can begin to put them together as a critical mass and begin to say to OHID and others, look, these are problem areas. And Sarah, when you talk about struggling to understand what the systems are like at ICS and ICB level, this doesn't help you at all, but you're not alone. Most people we speak to at the moment are saying exactly the same thing, and there is a slightly kind of unkind maybe sense that people setting up the new organizations are locked in battles about corner offices and car parking spaces and so on, and it's quite kind of tricky to penetrate that. So I don't know what the answer is, and I'm sure you're plugging away at all of the right things, but you're definitely not alone.
It is helpful to know that we're not alone.
Yes, thank you. If nothing else comes out of this kind of group hug at the end of the meeting, might be a good thing. So Jill and then Paul.
I picked up a bit, Sarah said something that's just, again, prompted me to reflect on just learning from the kind of vaccination program. One of the things that I've been really, I don't know why I was surprised, to be honest, we have within the COVID vaccination program possibly the best data collection when it comes to inequalities and what we understand about the population and who's taking up offers of the vaccine and why and all that sort of stuff, than any other NHS program. And there is, compared to every other NHS program, there is generally one equality and health inequality impact assessment for a whole program. The vaccine program has about 7, and then at a regional level it's got them, and then at a system level it's got them. It's the most EHEI'd program ever, but despite all of that, national decisions are made on that top level data cut. So as soon as you start cutting down to a more local level or to a population that's invisible, like our population, you don't see it at the national level. So decisions on vaccination at a national level were simply made based on that cut. Didn't make any allowance for the fact that actually how would this then translate to a regional level. And bearing in mind what I say about the amount of data, so it's become no surprise to me that this national programme decisions basically make no account for the experiences of inclusion health populations, because they're not even capable of doing it when we have got the data on much bigger populations. So there's something about kind of how we support the transition to that being a possibility, or we decide that what's an appropriate level, and is it that actually the data needs to be more appropriate at ICS or in a regional level? Are we ever going to get to the point of a national data system, which is what I suppose Sam's ambition is? So what's our role in between all of that? Because I think, I suppose just saying, well, you need to take more account of inclusion health isn't going to happen overnight. And I can I don't know, I'm speaking out loud, but it's just something about that invisibility of our population at a national level is just really, really surprising, even when you're talking about bigger populations. I know, Sam.
That's interesting. Is the problem there that inclusion health populations weren't accurately recorded, or that at a national level the numbers relatively are too small to appear relevant? What's the issue?
Bit of both, to be honest, I think.
Okay, thank you. Thank you. Paul.
I just wanted to come back to your point about PCNs. Sorry, I should say my name is Paul O'Reilly. I'm a GP at Dr. Hickey Surgery in Westminster. We're very fortunate having a very good relationship with our PCN, and there are many ways, as Nigel says, that PCNs are very bound by the guidance that they're given, but there is quite a lot of local flexibility. So, for example, in the ARRS program, I was mentioned, there's total inflexibility about who you can hire, but there is total flexibility about what you can do for them once you've hired them. And so, for example, there are lots of creative things that one could do with community pharmacists, clinical pharmacists that you can hire. One thing that our PCNs have been willing to do is to give us a nominal weighting of our population, which is 4 times greater than our actual population, in terms of the personal resources that they will give to us. And as a result, we're probably going to get 50% of a clinical pharmacist. And that's going to be really useful to us in supporting our opiate substitution program, and also managing a lot of the interface work between ourselves, prisons, hospitals, and all the ways in which other people change our prescribing, sometimes for the better and sometimes not. And the other area of creativity that I think people might look to is the development funding, which is very free in its usage. And we've got a proposal in that will help us with our hepatitis C program. So I think there are unintended, perhaps, areas of flexibility that can be looked at.
That's really helpful. And I guess to unlock those, I know you put a lot of time and effort into your relationship with the CCG. Do you think that's a significant part of how you've made your population visible in Westminster?
Yes, and obviously, I know nobody wants to be on more committees than they have to, but sometimes if you are willing to go onto the LMC and the CCG board, those kinds of things, it can really help just to keep your population visible. I always feel that one of our responsibilities as homeless GPs, and indeed workers, healthcare workers working with homeless people, is to represent our people as much and as often as we can in fora to which our people will never get access.
Thank you. That's an inspiring thought. So, Alex, you've got your hand up, and maybe you'd like to follow your comments and segue into your update and concluding remarks.
Okay. Well, so I just actually perhaps a bit more conversation if people have views on this. But one of the areas which we've done a lot of work on in the past is cuts both ways. Think about the workforce, and there is Ruben on a workforce strategy. I was struck by how it's one of Jeremy Hunt's issues in that picture we saw of Jeremy Hunt earlier, how he's got that surprised look always, hasn't he, which strikes me. But he is certainly majoring on kind of workforce being an issue, and we've certainly experienced, for example, in the kind of, as we've been supporting a number of new pathway teams, that the challenge of recruiting people is intense, which we know is a system-wide thing. We've done a lot of work over the years trying to get alongside people like Health Education England, which itself, I believe, is being folded back into NHS England. But I guess I'd be really interested in whether people think, which in a way is not quite on Dee's list, but should we keep plugging away in that? Some of it is about credentialing and making inclusion health a visible thing almost for you guys professionally as a discipline, it's a legitimate career, and therefore it begins to attract status and perhaps money. And or should we be doing some work to try and evidence the kind of workforce challenge within our own terrain, in that we know lots of colleagues struggle to recruit, and is that a way in? The thing I'm not close to is how there's lots of talk in the health press about how the government is refusing really to countenance a workforce strategy, and it keeps putting that into long grass because they're frightened, I think, that it shows just what a challenge is faced across health and particularly social care. And yet there's also a groundswell of people saying, well, we've got to think about these issues, and we've got to system has to do some planning about workforce, because that's one of the areas where it is really breaking, isn't it? So I'd just be really interested in people's thought, if there were any thoughts on that. Should it be something that Pathway and the faculty to continue to work on? And Dee and I were talking about this earlier, is that about developing sample trainings and models and curricula and operating on the professional bodies and, I don't know, Rocket of GPs or RCN? Or is it about trying to influence the system to do something, to allocate resources to make this a priority?
Paul, I see you got your hand up. Thoughts on making inclusion healthcare a career?
Yes, I think there's the opportunity here for us to present this to government as an opportunity, not a risk. Because I grant you, Alex, it's not always easy to recruit in inclusion health areas, but it's an awful lot easier than it is in mainstream. And so, for example, I have colleagues in the PCN coming to me, asking me if we could share recruitment, because people so want to work in general practice for homeless people, but don't want to work in mainstream. So if we give them a bit of the ice cream, will they also take a bit of the suet pudding? And now, unfortunately, we're not in a position to respond to that because we've got no vacancies. But I think there is an opportunity to say to government, if you do more of this, it will actually help you with your workforce problem, because it's fundamentally what most healthcare workers want to do. We get the opportunity to make stuff better. And we get the opportunity to work with people who have real opportunities for helping them to improve their situation. And this is a lot of fun to do. And if you do more of this, you will actually help your workforce problem. But you'll say it better than that.
All about vocation, isn't it? That's absolutely right. Diana, do you have a pediatric perspective?
Yes, I agree. I also think that there just needs to be a framework in place, and I think that would also recruit prospective people into the field as well. I supervise some medical students, and they're all very keen to get into this field, but they sort of don't know where to start or what sort of training do they need. And I think if you present also to the government a very keen framework, this is what we're going to teach our medical students moving forward, or health practitioners, I think that very much strengthens the argument.
Thank you. We're having similar discussions with the Royal College of Physicians, who are, looking at their sort of new generalist program and working towards trying to get a common understanding of the basic parameters of inclusion health. So there's lots of there's lots of opportunities out there, and yeah, this is an area of work that people come into with a great deal of enthusiasm and drive. So I think there's a lot we could do to be supporting that. So I've got my eye on the time. We're coming up to 20 past. So Alex, perhaps now might be the moment to invite you to give everybody a bit of an update about kind of where we are with Pathway.
Okay, thanks, Nigel. I mean, that's been really helpful and good conversation. And just to share on that generalist point, yes, we did quite a lot of work over the last 18 months with Professor Tro Schramm, who's now got some national role in redesigning its immediate postgraduate education. And she has built in, the Royal College of Physicians has said that generalism has to come back as a key thing that all medics should be trained on, which is really helpful. And again, following that, we've had several of the new, some other regional tier, but it is an HE regional role. There are now generalist clinical fellows of some sort who are trying to come up with exemplars for where people can come and practice what might be called general medical, but kind of intense generalism in medicine. And several of those regional people are saying we see inclusion health as being at the center of that. So it's worth, I think, I see Caroline Chalmers joined the course. So there's really nice, I think, Caroline, you did that event with kind of some psychiatry core trainees and the local person trying to bring people together. That was that program. And that feels very fruitful to me. We've had a couple of other people from other regions saying, can I connect? And we've been connecting people up to get more traction. I guess that's something, Nigel, you said ages ago, but kind of getting doctors young, of course, is a long-term, it's a different angle on system change. It's a long-term investment in hopefully the next 30 to 40 years of their career and their vocation. But the gains play out similarly over that 30 to 40 year period. But I think it's something we should definitely keep an eye on. The other quick bits of update just from Pathway, I think Nigel put it out on the faculty email list. So we're committing again to our next conference, and we've tried to learn some of the lessons from being perhaps overambitious, too cities and too much tech and too much all sorts this year, particularly London. We had a painful second day in all kinds of ways. However, we've committed again, as we do, 15th and 16th of March in 2023, we will be gathering together again. And I think we're saying we want to be in person. We think we want to say that really we can of course do a bit online where people really can't, but we really, really want to try and bring people together again and try and create an event where people are in the room together and sharing with that, and perhaps program slightly less content and give people a bit more time. So that's where we've got to. As a theme, we've thought that integration, some of the stuff Dee was talking about, is kind of the theme of the moment, and what is a core theme, integration. But at that level, beyond that, I'm now looking for volunteers to join our steering group, and also early doors suggestions for keynote or speakers you would like us to try and invite or nail onto our platform, who you'd like to hear from, or who you'd like to put some pressure on. Interestingly, I'm going to the NHS Confed conference tomorrow and Thursday, and we had colleagues who were there. Remember, we had Bola Owolabi close the conference this year, who two of our EBs are coming with me to the NHS Confed, and they were on the panel with her, you may recall, and they felt that they gave her quite a mauling, and afterwards was saying to me, was that too much? Did we really have a go too much? Interestingly, after the event, Bola sent me the most effusive message saying that was absolutely brilliant and I loved it and I'm here for you. So interesting what those platforms sometimes can help you do, whether we can get Bola to do anything more than be here for us, because I'm not quite sure what that means. We shall see, but working on it. So yeah, we're open now for volunteers either formally just join the conference steering group, and colleagues who've done that before, there's an exercise there, particularly to help us review all the submissions and papers, and actually within that boil down some themes and try and corral content, because a call for papers will come out shortly. But then also now is the time to begin to think of who we want to invite. Do we want to get a minister? We've had that before. Do we want to try and get senior NHS England officials on our platform, etc.? I picked up that Kevin Fenton is about to become president-elect of the Faculty of Public Health. Is he someone we should return to, for example? So there's a bit of news there. The other bit of news, again, I just want to share as he's sitting on his sofa. I see you, John. Just to say that John Connolly, we've been strong-arming John, or actually perhaps he's been leaping forwards to see if he might join Pathways core team for a day a week. He's going to do some more thinking about all of his amazing trauma thinking, particularly to think about the training side, and it's not confirmed yet, but kind of perhaps some ideas around train the trainer, or how can we create more materials which really help people develop on from his thinking and get better practice in that space. So really looking forward to having John with us shortly. A day a week, of course, is much less than we would like, but there you go. He's a busy man. So that's another bit of news from us. I think that's it, really. Two last things. So one, for London people, we are proposing to try and convene, as we were doing during COVID, another picnic in the park. Again, I'm trying to look around who was here. We had an amazing picnic last autumn. Jill was there, certainly, where some of us ended up having to carry some. It was a team building session. I'm blaming Jill, actually, where some members of the collective had to lift other members of the collective over the fence, because it turns out we'd been locked into Regent's Park, which is, of course, a gated royal park, and that provoked some quite good team building moments later in the evening as we tried to marshal some of our fellows out of the park. Anyway, we're just looking for a date. If you're in London, please come and join us. We'll email that around. And the last thing I just want to say is this: it's that people will have picked up that Nigel has announced some retirement plans, and this is his last formal meeting in the chair of these meetings. So I didn't think we could pass this evening without mentioning that. We are thinking of various celebratory things which Nigel won't be able to escape from. So again, we're hoping for a due early autumn, certainly, and some other things will come around to you about marking this moment. I think it's right, Nigel, to say that you're not running away anywhere particular, are you? So we're expecting to see you around, and he's promised me he's going to be on the end of the phone every now and then, and
Absolutely. I'm aspiring to have a sort of supernumerary figurehead role, so sort of generally background supported, but not getting in the way is what I'm aspiring to. And just listening to you speak there, I don't think you sufficiently sold the role of being on the conference organising committee. It's actually great fun. It only involves about 4 meetings. They're all virtual. They last a couple of hours, and it's a real opportunity to shape the next conference. And over the years, we've had, for example, a lot of the sort of fair health and focus on children and families came from particular members joining the conference organising committee. A focus on sex workers 1 year came from that. Thoughts around acquired brain injury. So it really is an opportunity to shape the focus of the conference. And for people who join that organising committee, you get a free or sponsored. It doesn't cost you anything to come to the conference for the 2 days. So it's well worth doing. So that's grand. Has anybody got any final comments or anything that they're burningly wishing to share? If not, I will take great pride in finishing my last meeting in the chair 2 minutes early and exactly on time. And thank everybody for coming along and for your contributions, and looking forward to seeing people in person and on screens before too long. Thanks everybody for coming along. Bye-bye.
Good night, Nigel.
Bye.
Thanks, everyone.